All right, guys, welcome back to another episode. There's millions across the country that will not need an introduction to today's guest. He was on episode 13, and I'm not kidding with millions, and I'll get into it. The reels that we've been putting out across the web are just exploding. So I like to call you, Dr. Boron. You're the surgeon that has blown up the internet and is continuing to blow up the internet, and I mean it. It's incredible, right? You've told such awesome stories in episode 13 that we're going to get into. I want to have you dig a little deeper because they're making a lot of waves out on the internet. So I'm going to dive into the first one.
Sure.
Is you mentioned or you told a story of getting shot in the liver, how it's just the worst. Okay, so
Yeah.
I have comments pulled up here that I'm gonna go through right now so you can
Okay.
see.
Yeah.
And I don't know, there's probably a couple thousand of them, but I want to highlight a few. So you had surgeons responding on there going, "Oh my gosh, it's horrendous. We run out of blood, all these different things." But
Yeah.
then
Yeah.
you got the people. I want you to start off by speaking to these people that say things like, "Really? How could that be the worst? You're telling me it's worse than a headshot? What about a shot to the heart?" But we got a lot of those. So they're
Yeah. Yeah.
not getting it. And I want you to dispel it now, what you really meant by it.
Yeah. So, there's, different types of trauma, right? So there's stuff that kills you immediately, and they never make it to the hospital.
Mhm.
There's stuff that kills you within an hour, and that's that kind of golden hour of trauma that they talk about. Where if you get to a high level trauma center within that hour, and we can start doing things, you have a shot kind of to live through that. And
Okay.
then there's the long term trauma, the gunshot wounds to like the lower abdomen and stuff, where untreated, you'll live for days until an infection kind of takes over. And so the liver is the interesting one because depending on the caliber and depending on exactly what it hits, you'll live. If you're in a major metro, you'll live until you get to the hospital. And so it's the most devastating injury of people that live to get to the hospital. The chance of you living to get to the hospital with a direct shot to the heart are minimal.
Minimal.
I have a great story about that we can go into on a later
Yep.
portion
I'll
of
write it.
if you
I'll note it so we get into it. Yep.
want. And then headshots. I'm not a neurosurgeon, so I'm not going to sit here and describe the intricacies of brain trauma. But
Yeah.
in my experience, headshots are either fine or they're not. So I remember specifically there was a U.S. federal agent in Chicago who was on a steakhouse and got kind of snuck up on in his car and shot point blank, kind of in the head. Um, and it was a big deal. It was a federal agent. Came with a lot of people with him.
Yep.
And he was there and he was talking and it kind of missed everything. Kind of went through his sinuses and kind of out the side above his ear and kind of took a little bit of, the bones around his orbit. And he was fine. And there was a little brain bleed, but little brain bleeds aren't a big deal.
Yeah.
Then there's catastrophic injuries where, people get shot point blank or people get headshots and it takes out a big chunk of their brain. And those patients live to come to the hospital, but they ultimately don't usually do well. Every now and then people have remarkable recoveries. But kind of those massive head traumas are usually patients that end up not doing well and going to long term rehabilitation, or they end up being the patients that end up being organ donors because you can live for a really long time if it doesn't involve your brain stem, and it just kind of the top of your brain where you do executive reasoning and thinking. You can live forever, until something else takes you. Your heart, your lungs, your circulation's fine. You just don't have any ability to function.
Yeah.
And so those patients end up being a lot of times organ donors or have a extremely, extremely long um, recovery. So
Hmm.
the liver shot, and all the points are well taken.
Yeah.
As a trauma surgeon, there's a whole team of surgeons that work on these patients. There's the neurosurgeons who take care of the brain and the spine. There's the orthopedic surgeons who take care of bones and fractures and things like that. And I'm sure if you asked either one of them, they have a terrible injury that they don't want to see. That's the worst thing they can go out. And,
Yeah.
a terrible hip fracture for an orthopedic surgeon or a pelvic fracture
Yeah.
is devastating. And, I've sat there where a neurosurgeon has tried to stop the bleeding in someone's brain and given the patient 70 units of blood because, your brain gets a lot of blood. And if there's open blood vessels in there, you bleed significantly. So, of the things you can live through and make it to the hospital in that kind of golden hour. And then the other thing is, what can you fix, right? So, I trauma surgery and medical interventions and technology has come a long way.
Mhm.
There are still things that happen that, I don't know what the best way to fix that is. And we sit there. Sometimes you stabilize the patient and you kind of get them out of that golden hour, and they're sitting in your ICU with a partial band-aid on what was the problem. And you sit there with your partners the next morning and go, well, what do we do now? Um, and a liver case, I remember one of my partners, this wasn't my case, came in, bad gunshot wound to the liver. And like one of the principles of like liver surgery, especially in trauma, is you kind of pack it tight, right? It's your liver sits up under your rib cage, and you just try to put the pieces back together and push it back as tight as it can. And you pack, cotton packs around it. And you're really just like putting pressure on a wound. Like you're trying to put that liver back together and put enough pressure on it where the pressure you're putting around it is larger than the blood pressure that's perfusing through that liver,
Okay.
and it kind of stops.
Mhm.
And he had done that and done like the normal kind of trauma pack, and it didn't stop bleeding. And he ended up just shoving a metal retractor kind of in the abdomen with the butt of it pressed up against the liver and the other piece pushing against the side of the abdomen to get more pressure on it. And when he did that, the bleeding stopped, but the bleeding was coming from behind the liver, and kind of the liver is kind of held on by two things. There's suspensory ligaments on top of it that kind of hold it to your rib cage, which you can take down and kind of get to a piece of the liver. But there's a piece of the liver back there in kind of the retroperitoneum, which is where your kidneys and your aorta and your vena cava live.
Yeah.
And your liver chucks into the vena cava, which is the big vein in the abdomen. And there is no way to get to that without taking out the liver. There's no, because you're fighting the rib cage, you can't get it. So there's parts of the liver that can get injured
Yeah.
where there's just no good way to get to it. And then you get to it and you're like, well, what do I do now? So I remember sitting with him and a bunch of my partners the next morning. We're all talking and like, yeah, this is what I did. And the guy's alive and he's in rough shape, but like he's alive. And we sat there for an hour and a half kind of discussing options of like, what do we do now? So when we take him to the OR, we don't kill him now.
Yeah.
And what we decided to do was call the transplant surgeons. Since we had time now, we stabilized them. Not we, he stabilized them enough where we had some time to think about it. And we ended up calling the transplant surgeons, and we called the perfusion team and ended up putting the patient on bypass to kind of oxygenate his blood so his blood didn't necessarily need to return to his lungs. And then we had the liver surgeon partially explant his liver to try to get to this. It didn't work, and the patient ultimately died on the table during that second operation. But it's kind of that principle of trauma surgery of like, let me stable if I don't have the answer now,
Yeah.
and you know, experience in trauma surgery is the number one thing because there are so many things that happen and ways things happen that unless you've seen it, you really don't understand. And sometimes books don't give it a great understanding.
Yeah.
But give myself time and let me call some people and see if they have an idea of how to fix this too.
Yeah.
And the liver is the ultimate example of that. You know, there are within general surgery, there's a subset and a specialty you can do that's just liver and kind of pancreas surgery.
Wow.
Because there's a lot going on and it is specialized and there are unique techniques. And, you know, the best surgeons I've ever met, bar none, were the guys who did liver transplant. Because you really have to have just big, you know, for a better term, big balls to do it, man. Like it is a very high stakes area, and you're taking a patient that's living,
Yeah.
admittedly dying from liver failure,
Right.
but you're taking it out, you're taking their liver out, and then have the confidence that you have a good liver on the back table and have the confidence that you can put that back in and get it back to work.
Right.
And if you don't, if you can't get that liver back in and back working, that patient just dies on the table.
Wow.
So it's an amazing subset of surgery that I was always amazed by the people who did it because it's really, and these are tough surgeries. You know, lung transplant and liver transplant are just the windows that you're working in, the necessity of the structures that you're working on. It's very high stakes. It's
Yeah.
very high stakes.
Yeah.
And, you know, I'm going to ignore neurosurgery because I don't know it. Neurosurgery is very tough. Those guys are very, very smart and very, very technical. I don't understand much of what they do.
Yeah. All right. So we'll excluding that one. That makes a lot of sense. What about the blood? One of the guys, he said he's a surgeon. So I mean, his comment makes sense. He said
Yeah.
he was speaking to the other people inside the comments and said, hey, what Dr. Boron's really talking about is just what you said is what you can, it's the worst that you're going to survive,
Yeah.
obviously.
Yeah.
Right. But he made that comment about how much blood. Is that true? Like with the liver, do you go through tons of blood?
Trauma surgery and the bad traumas is a blood loss problem.
Okay.
Um, and like we talked about, that initial hour, like the difference in um, die immediately versus die within an hour versus die in hours to weeks.
Right.
The die immediately is usually a blood oxygenation problem.
Okay.
You know, you're taking out something that no longer allows oxygen to get to your blood.
Okay.
So a heart shot, all of a sudden you're not perfusing your lungs with blood. They don't get oxygen.
Boom.
There's only so much you can do. The heart's not pumping. It's not circulating blood. Dead.
Yeah.
A brain shot or a spine shot that cuts off the nerves that go to your heart and your vital organs. If you take that out, you know, blood's no longer being oxygenated. It's no longer pumping around. You just die.
You just die.
The other problem is just the amount of blood. And so the hour is really the amount of blood that you're tolerable to lose. Um, and so a lot of advances have been done in kind of pre-hospital work to advance kind of how soon these patients get blood because for the most part what that hour is how quick can we start giving blood to these patients. That's that golden hour. And so military and some trauma centers are now carrying whole blood, on their helicopters. And if the patient's in a bad way, when they pick them up, they can start giving them blood right in the helicopter. That buys you extra time. When
Yeah.
you get to a hospital or a high level center that's not kind of in a forward deployed military situation, we break out blood into 4 different parts, because you don't always need all the parts at one time, and it stretches blood donation farther. So blood is broken out into the red blood cells, which are what we normally think of when we think about blood, the oxygen carrying molecule of the blood. Then we break it out into 3 different clotting factors: FFP, cryo, and platelets. Those are each separate bags that you kind of hang, and those 3 pieces are what makes your blood clot and what ultimately stops bleeding with an injury. We have multiple tests that can tell us exactly, kind of in real time, well, we're giving him blood, we're giving him blood, we're giving him blood. He needs some cryo now, he needs some platelets to try to get this blood to act in a way that would stop bleeding.
Yeah.
But for a lot of these patients and the really bad injuries, you're pumping blood in. And we have big bore needles that we can stick in your groin. And then machines that literally put these blood bags under pressure, and they can squeeze 2 units of blood into the body in about 30 seconds. And so you can get, there's trauma centers have something called a mass transfusion protocol.
Okay.
Where normal blood transfusion is, you order it, it takes some time, you get there, you give it, whatever. And you order each individual unit. A mass transfusion protocol is a fire hose. And so it's telling the blood bank that, hey, I got a guy bleeding. Until I tell you to stop, keep sending blood. And so in places I've worked, it's just been coolers. And so when they know a big trauma's coming in, the first cooler will be sitting in there that just has 6 units of blood in it. We go there, and every 15 minutes, another cooler will arrive until you tell them to stop. And, the trauma unit I worked in Chicago, which does such a high volume of this stuff and is so proficient at it, no matter where that patient went in the hospital, those coolers would find that patient. So you took a patient to the OR, those coolers would start showing up in the OR. And you would go through in a bad traumas, and a lot of the bad traumas people die, but in the course of them dying, you'd give them 100, 120 units of blood, which is their blood volume many times over. Because there's also this phenomenon of, so you stopped the problem, but they've gotten so much blood now that their blood no longer works well and it won't clot. And so things that shouldn't be bleeding are bleeding now. And you're trying to restore the function of the blood by giving all those other parts of the blood.
Yeah.
We can give, IV clotting factors and things like that help it. But sometimes the body gets so out of whack with its blood that you just never catch up. And you fix the big problem, but all this little stuff that really shouldn't be bleeding, you don't have a good way to stop it, and they just keep bleeding out. And they just keep bleeding out. And if you're young, you can do that for a while. Admittedly, most gunshot wound victims and trauma patients are younger, so they have a little bit more physiologic reserve. And they can go for a while. And there's been patients that, we've taken them to the OR, fixed the problem, taken them back to the ICU, and then for the next 2 or 3 hours have just continually given them blood. And after about 2 or 3 hours, you go, well, let's go back to the OR and look again and see if we missed something. And you take them back. Sometimes you did miss something. It wasn't bleeding first time you were there, but they have enough blood pressure now where now it's bleeding. You're like, oh, okay, let's fix that. And sometimes you go back and you're like, everything's just kind of bleeding. And you pack them again. You pack everything real tight, hoping to kind of get that pressure on it.
Yeah.
And then you take them back and you try again.
Wow.
And there are patients that I can think of that, we'd been doing that for like 12 hours. We've taken him back to the OR 3 times. And you're like, I don't know if this guy's going to make it. And I remember, you know, doing a Hail Mary. There's all these kind of injection clotting factors that are made for hemophilia and stuff like that,
Yep.
that are risky to give. You know, you can stop bleeding, but in bleeding, you make clots. Um, and so you can also get a clot in your heart, to our earlier conversation.
Yeah.
You can get a clot in your brain. You can stroke these patients out. And so,
Jeez.
you know, you have to be careful with these. And if we don't give this, is this patient going to die from bleeding? I know giving this may cause this patient to stroke, but maybe not. And maybe we give it a try. And there was a patient that we had done it for 12, 14 hours. And we were just transfusing him. We had taken him to the OR a couple times, couldn't get him to stop bleeding. And we ended up pulling the trigger on one of these clotting factors. And he turned around. And the next day we brought him to the OR, closed up his belly. 4 days later, he was, you know, breathing on his own and talking. And it was one of those things where it's like, it really makes you think of like, oh, I had written this guy kind of off. I mean, I was still trying as hard as I could, but in the back of my brain, I was like, I kind of can see the way this is going.
Yeah.
And then he turned around and he walked out of that hospital after getting, you know, 180 units of blood. So, you know, the human body is amazing. Everybody reacts differently. And, you know, there are miracles. There are things that happen
Yeah.
within a trauma unit that defy my reasonable expectation of what a body can do. And I always view those as miracles. And miracles do happen in the trauma unit.
Yeah. So speaking of, I want to see this case through your eyes. So the last episode that went up was episode 59. And it was a guy that came in through one of your YouTube shorts, which is so cool. So you had a YouTube short out there. I think it was about a gunshot in the heart, which we're going to get into that story. And this guy from Vidalia, Georgia, if I'm even saying that the right way, writes in the comments out there on the internet. And he said, hey, trauma surgeons are miracle workers. I would like to share my case. Here's a little bit of it. So he wrote a little bit of the comment. Well, it was so good when I did the pre-interview that we launched a full episode yesterday. So he went up, it's episode 59. In a nutshell, he's 55 now. He was 18 when it happened. He got shot right in the center with a 30-30 from 100 yards. Okay, a 30-30 hunting rifle. It doesn't go out the back. Miraculously, it goes down his windpipe 5 inches, blows out the lung. Fast forwarding, he goes 3 hours without any kind of pain medication or anything. Has an emergency trach that they used the bullet hole for the trach, but the surgeon had to cut a chest tube with no anesthesia, no local, no nothing.
Yeah.
So he's 55 now, and he's got the scars, obviously, but he's alive and functioning perfectly normal, and which is incredible. But then he goes to college a couple months later, which was really cool. And his roommate goes, can I ask about the things on your neck, the scars? And it turns out that the roommate's dad was the surgeon in the case, which is right.
Yeah.
So I know you and I are aligned there, what we're thinking, like that's a bigger story. But try to get me in the seat of that amount of trauma through your eyes, through the eyes of a surgeon.
Yeah. Well, the first thing that comes to mind, we'll get into like the technical, is for a trauma surgeon, hearing follow-up and seeing follow-up is amazing. Because most of the time these patients leave and you just never see them again. And, you know, they're a night of your life where, you know, you didn't sleep, you were pouring yourself into them. And then they just kind of disappear. And you're like, I wonder how that guy's doing. I wonder if he has a good life. I wonder, you know, is he happy that he's still alive? Because sometimes people come back and they're like, I wish I died during that. And you're like, you know, it's really, really hard but to hear the follow-up and like, I'm sure that trauma surgeon got, you know, the fact that kid's at college now and doing well and telling the story, like what an amazing experience for that trauma surgeon.
Yeah.
The as far as like the technical aspects of when they come in, and I think this is where experience comes back, and the people who do trauma a lot do it in a much more kind of organized fashion. A general surgeon who doesn't do trauma a ton or doesn't have a ton of trauma training, the inclination is when somebody's in like a really bad way to just kind of go for it, right? Like, oh, he got shot in the neck. Let me open this neck. Let me see if I can figure out what's going on. But what really has to happen is you need to take care of the ABCs of trauma. So airway, breathing, and circulation. So that's kind of the first, anytime somebody comes in, you kind of do those three things over and over again until you get them satisfied.
Okay.
And when a patient starts not doing well, you go back to the ABCs. So this guy was shot in his airway. You put that trach in, you have an airway. Are his lungs working? Are his lungs able to get oxygen to the blood?
Yeah.
That's why he got that chest tube. One of his lungs had collapsed.
Yep.
And so they need to re-expand that lung. So we need to do that. So that tube goes in. Now those lungs are working. Now I have an airway. So he's getting air in. That air is now able to get into the blood. And now do I have enough blood in the body to get that oxygen to the rest of the body? So that's where that kind of blood transfusion comes from.
Yeah, got it.
And when someone's not doing well, you go back to those things. Like, which one are we doing? Once you get that, once you get a patient relatively stable-ish, they're not active, their blood pressure is reading, they have some sort of oxygen saturation on the monitor.
Yeah.
You need to take a breath, and it's tough to do, but you need to take a breath, and then you need to, what they called at, where I worked at Chicago, you need to solve the puzzle. And the puzzle is, it's almost like a kid's game. Very high stakes, but it's a kid's game. You need to find the bullets, or you need to find the bullet holes. So you need to come up with an even number.
Wow. Wow. What a way to look at it.
Right? And so the guy had one shot here. We look, and in Chicago, we did it all the time, is once we got ABCs taken care of, the next thing was roll that patient and let's find bullet holes. And it seems like an easy task. Bullet holes can hide in really weird spots. If the patient is obese, it can be under a fold. If they were also in some kind of accident and fell, there can be kind of road rash or like scraping all over. Sometimes, depending, civilian caliber bullets can be very small too.
Yeah,
and
sure.
so the hole is very small. And so the biggest mistake is not doing that and not trying to solve the puzzle. So you look, find the bullet holes. Okay, we have 3 bullet holes.
Mm-hmm.
So there's a bullet somewhere still in this guy. And so you start doing x-rays, right? You start doing x-rays looking for that bullet somewhere within that guy.
Yeah, yeah.
Because if you can't connect, let's just take a one shot, guy was shot once, had his one bullet hole, no exit, and it's here. Did it go up?
His went down.
And it's sitting in his neck. Do we need to worry about this? Did it go down and is now in his chest? Did it go down and is now in his liver? And your next step and what you decide to do next, there are lots of options of how you can do it. But it's, where do we go? What do we do? And so coming up with, and sometimes you don't, and the worst cases I've ever had were before I went to the OR, I didn't have a good idea. Something happened where I couldn't find a bullet. I gave up looking for the bullet. We looked this guy all over. He has one gunshot hole. We took x-rays down to his ankles and couldn't find this bullet. And you're going, well, okay, I guess I'll go. But those are all universally a flail. Not that you can't get the job done, but universally a flail.
Yeah.
And so you're trying to figure out where that went. And so he had the one bullet hole here. part of that breathing, A-B breathing,
Yeah.
is you take a chest x-ray and you can see if a lung is collapsed or not. You can literally, if the patient's in a tough way, you can literally just stick your finger in there. Cut a hole, stick your finger in there, root it around, and that'll give you time to get the tube and the rest of it.
Yeah. Yeah.
But so it sounds like he had the bullet hole. They found the projectile in his lung. The lung was down. They put a tube in.
Yep.
Tube goes in, and then the questions that you have with that tube that's now sitting in that chest cavity are how much air is coming out of this, i.e., how big's the hole in the lung, and how much blood's coming out of it. Because I've had, if you damage the lung enough, the lung gets a lot of blood. And so if it's bleeding too much, and usually it's about a liter of blood, if that comes out immediately and it's not stopping, you got to do something surgically to stop that bleeding.
Right.
And so you have to go repair that lung, whether it's, stapling off a chunk of it, putting big stitches in it, or if too much air is coming out of it, then the air isn't inflating the lungs, it's just going right out the tube. And then you have to kind of plug that hole by stitching it closed or stapling it closed, so the air actually goes back into the lung and expands the lung to get oxygen in it. And so this is a tough area, because I think of a shot here, and you have big blood vessels in your neck, then you have your air pipe, and then your esophagus, kind of the tube that food goes down.
Okay. Yep.
And so the airway, if they're, they put that trach in, if they're oxygenating through that, the actual injury to that we can figure out at a later time. You can do a CT scan with contrast and really look at the blood vessels in the neck to see if something needs to be done.
Yep.
If they're damaged and bleeding, sometimes you can put a stent in them or something like that. And then the esophagus. So the esophagus is important. And again, not in this first hour, but if you have a hole in your esophagus and you're not eating, you don't really note it. But you'll get a really bad infection, right? Because all that spit and saliva that you're swallowing is now going into your neck cavity. And your neck cavity has passageway all the way down into your chest. And so that plane of your body goes all the way down into your chest. And so that's a bad place to get an infection, right? It's called median stenitis. So the mediastinum is that area kind of that's your heart lives in and kind of is in front of your chest.
Yeah.
And if infection gets down there, is it fixable? Sure. It's a problem though. And being able to identify the hole in the esophagus early, fix it early. Because the other problem is that if you leave something too long and that area is now infected, when you go to fix it, and everything's fixed with sutures and staples, right? If you leave that too long, whatever repair you do of it, if it's in an infected field, is more likely to break down. So there's a hole in the esophagus, you fix it, found it, fixed it, but there's an infection around it. That infection is going to eat those stitches you just put in it and dissolve them, and then you have a hole in the esophagus again.
Wow.
And so you end up, there are patients that this becomes a real problem.
Yeah.
And you end up just taking out a chunk of the esophagus. And it's like, I can't fix this right now. It's infected. Nothing I do repair-wise is going to fix this. Mm-hmm. And so we're just going to cut it out. And so you end up cutting it out. You take what's left of their esophagus from their mouth and kind of bring it out the side of their neck. It's called a spit fistula. And basically you put a bag on the side of the neck and the spit that you swallow comes out there. And then you put a feeding tube in their stomach to get them nutrition, and you live to fight another day. There are ways to reconstruct an esophagus. Yeah. They're a big deal. Esophageal surgery is very tough. Yeah. I'm not capable of doing the surgery, so it's too technical for my knowledge. But chest surgeon with combination with a general surgeon or colorectal surgeon at a later date when all the infection's gone, you can take a big chunk of your colon, rotate it on its blood supply, kind of put it up there, and then your new esophagus is a piece of your colon.
Wow. That's unbelievable. How do
But the joke with that surgery is always, the surgery worked great, but my breath stinks now. But
Oh my gosh, that's awesome. So, how do you measure that amount of pain? He's telling me, and I'm like, I don't know if I want to pass out. My body's cold. I got goosebumps. I'm like, I can't imagine it. No anesthesia, no local, no nothing. How much
yeah,
pain is that?
Jeff, I don't know. I think unless you experience it, I've had bad sports injuries and
Yeah.
they hurt a lot. and for me, that was a 10 out of 10 pain. But, I think we're getting better as a medical entity of treating pain and addressing pain.
Hmm.
But a lot of times it's a secondary thought, right? Like this guy needs to live
Yeah.
and
Sure.
I
Oh,
don't
yeah.
have time. And the other real problem is if you're in really bad extremis where your blood pressure is really low and your heart rate's really low, and
Hmm.
pain medicine can make that worse. So pain medicine can make your blood pressure drop, pain medicine can make your heart rate drop. And so sometimes you don't have enough wiggle room to really deal with. And so you're kind of like,
Yeah.
this guy's heart rate's in the 50s and his blood pressure's really low. Maybe a little pain actually can help it a little bit because I can't give him pain medicine right now because if his heart rate and his blood pressure drops any lower, he's going to code. Um,
Oh,
and so it's a paradigm. Once we stabilize them, let's keep this patient comfortable. But
yeah.
pain really comes secondary to living.
Yeah.
But I can't imagine. And talking to trauma patients after, like the pain they experience is really significant. And we're doing better. We have very different modalities now. There's drug development that's going on for a new class of pain medicine that work on a different pathway that has a lot of hope. Um, but pain's one of those topics. It's not well treated because of what we talked about initially.
Yeah.
Then you kind of go into this mode of you need to be comfortable. But if they're in the hospital for a long period of time and they have, months of pain medicine and narcotic administration,
Mm.
there's a chance that they leave the hospital addicted to pain medicine.
Yeah. Right.
And that's, a lot of trauma patients getting them finally off that last pain medicine is a big deal. And it's not their fault. It's not their
Right.
fault. Like
Right.
the drugs are what they are and their body got real used to having them. And
Yeah.
so when they don't have them, they feel terrible and the pain comes back and what they're experiencing is true, but
Hmm.
it's medicine. And so it's a balance.
Yeah. All right. Incredible. Wow. Whew. Moving on. What I'm going to speak to a large category of folks, I think particularly in the southeast of the country, but it's a law that's spreading out across the country that drive around on these two-wheeled motorcycles, man, without helmets. I don't care if the law says I can go without it or I need it or I don't need it, whatever. I'm thinking I'm wearing one, but I respect their opinion and not wear one. My question is, when these types of accidents come in, do they ever really recover? Helmetless accidents on motorcycles?
It depends. There is a large spectrum of it, right? Like it depends what gets hit, right? There can be a guy not wearing a helmet going a moderate rate of speed that, gets hit kind of lower torso, lays his bike down, and his head didn't really take the brunt of it. His shoulder, his hips, his pelvis took the
Yeah,
brunt of it.
yeah,
I would say that's more rare. Your head, especially on a motorcycle, is usually the first thing that hits something.
Yeah.
And it can be really devastating. And again, not a neurosurgeon. Brain injuries come in all forms and fashion.
Yeah.
Sometimes they recover. Sometimes it's a short recovery. Sometimes it's a long recovery. Sometimes they don't recover. And brain's one of those things where when it's injured bad, there's not much you can do. There's you let it heal and see what comes back. You can't get a brain replacement. There's no implant that you can put in there that's going to reconnect the neurons.
Yeah.
And so, there's great rehab facilities. Atlanta, where we live, has this amazing neuro rehab facility downtown that does miracles, that patients that I didn't have much hope for making a meaningful recovery, you see 6 months later after that rehab, and they're doing great.
Oh,
And so even when it's hopeless, if there's some activity in the brain, there's some hope.
yeah.
Um, but a lot of times it's a long road to hope. And the helmet law doesn't do a great job. There's some nuance to that too. And so what you wear on your head as a helmet matters. And helmets that have been tested to be effective and really hold back kind of and give you the best chance have a Department of Transportation sticker on them, where the Department of Transportation has certified that this helmet meets whatever criteria helmets need to.
Whatever criteria.
But they'll have a DOT sticker, and normally they're the ones that wrap around your face, have a face mask, go low on the bottom of your neck to give kind of that most precious part of your neck some support.
Yep.
They're hot, they're hot, they're tight, they're not comfortable.
Right.
But there's also a bunch of helmets that don't meet that criteria that people wear to get away from the helmet law. They're affectionately known as brain buckets in the trauma bay. And they're the little tiny hats that like you see in biker movies and stuff.
Yeah, right.
And they don't offer any protection. And I remember pulling one off of somebody at one point. And it had like a warning on the inside of like, this is for novelty use only. Do not use this for protection, or like does not meet DOT standards for. And the guy was wearing it and he had a bad head injury. And you're just like, man, if you would have read that warning.
Right.
But, he was, the cop could pull him over and he's wearing a helmet.
Yeah.
But that effectively does nothing.
Just because you can doesn't mean you should, right?
Exactly.
Comes down to. All right. What would be good questions? I have a medical examiner from GBI coming on in a couple weeks. I'm just curious.
Oh, cool.
Your eyes. What would be good? I know what I want to ask him. What would be some cool stuff to ask him?
I think really like when something happens, like what are you looking for? Like what makes a case? Like what solves answers? Because, my experience with the investigations and stuff like that is they would come interview, they're in a car accident or motorcycle crash, interview them, try to get some information from them, sometimes take blood to do toxicology. Or a bullet, they come in like, who, do you know who did this to you?
Right.
A lot of times people do.
Yeah.
And then the other thing was if we ever removed a bullet, and I think we talked about on the last podcast, like a lot of times you don't go after the bullet because it can be a real pain in the butt and you don't need to. But in the course of everything, sometimes you end up with a bullet. And what we had done was, there has to be a chain of custody with that bullet. And so we pass it off. It stays in a field. Somebody from hospital security will come and sign for it. So there's a chain of custody of that bullet, like back to that patient. What happens after that? I have no idea. but like that was my experience, with law enforcement as it relates to this was, be very careful when you pull out something or a bullet or something. Make sure that like it has chain of custody. So there's whatever they do, there's a possibility that this can be used.
Yeah.
But a lot of times, the question that I got from not GBI, but other investigative bureaus was, where did the bullet enter? And if there's multiple gunshot wounds, I have no idea. Like that one could be an entrance, that could be an exit, could be the other way. You would like to think that, by ballistic science, the small hole is the entrance and the bigger hole is the exit. That doesn't always pan out. There's a lot of things. So
It doesn't.
no, I mean, that's I was taught, and one of my partners who is in Chicago, who is one of the most amazing people I've ever met, who was also a Chicago SWAT officer. He was a trauma surgeon and Chicago SWAT officer, and really just like the world's most interesting human. Had a wonderful perspective of just the totality of trauma care.
Yeah.
And, he taught me that like you can't say which one's which. It's impossible to figure it out.
That's
So a lot of times you have a guess. He's like, but you're going to be wrong sometimes, so I wouldn't say it.
Wow. Okay. That's really cool. So chain of custody is an incredible term. I never heard that before as it relates to a bullet. So
Yeah.
you're pulling it out, you're putting it on something, it's going in some kind of bag, you said, or whatever.
Like a cup. It's covered in blood, so like a cup.
Yeah. Comes to get it? Like an actual.
So it depends on each side, but usually a hospital security. So each hospital has some type of security force, and they have protocols of, the nurse signs that I took this out of the body, I took this off the surgical field.
Yeah.
The hospital security comes in, signs for it, saying I'm removing this from this OR at this time, and then hands it to, the local or the federal investigative bureau, and they sign for it being, So there's a trace of this bullet came from this body on this date.
Yeah. Yeah. Got it. Okay. There was a gunshot story that you started in the beginning, but you said you want to come back to and remind you. So I wrote it down. It had to do with the heart and a gunshot.
Yeah. It's one of my favorite. It's one of my favorite cases that it was one of those things where I just didn't know. So a person came in, single gunshot wound, around the middle of the chest.
Okay.
Came in talking, and we were, it was relatively stable. So we were, starting the X-rays, airway, breathing, circulation, all that. And he didn't even go into like the big trauma bay, right? So there's a big trauma bay. You only have 2 of those, and then there's 10 other ones that you can deal with most of the other stuff in.
Yeah.
He came in talking and was stable, and everybody was like, all right, I guess put him. Yeah. And you're like, all right. And then we're talking to him, and I was like, oh man, he got shot there, but there's one hole. Can't really figure it out. We haven't taken X-ray yet, but he's breathing fine. And, sometimes random things happen. Like if it was a glancing blow, like maybe it bounced off his sternum and just popped out. Let's figure this out. We got time. He's stable. And I remember sitting there and talking to him, and then he just dropped dead. He was fine and then dead. And you're like, oh man, okay, misjudged that. And so when someone dies on you, and usually you got about 10 minutes in here,
Yeah.
the move is to cut open their left chest. So you can do a lot of things from that left chest. So literally just knife, middle of the chest to as far back as you can get, kind of midway through the chest, put in a big retractor. You're breaking a bunch of ribs as you do it, but spread that hole as big as you can and see what you see, right? And so the only place you really can't get to is the right chest. You can get to the heart, you can get to the great vessels, you can get to the left lung. The only thing is the right chest. And so a lot of times when you do this, you put a chest tube into that right chest just to cover your butt. So you cut it open. What do you see? Sometimes a bunch of blood comes out. Sometimes it didn't. This case, a good amount of blood came out, but not a ton. So what you're doing is two things. Is you're opening up the sac that engulfs the heart, because there's something you can get called cardiac tamponade. And what that is basically there's a sac that envelops the heart. And if you're bleeding from your heart or something around it, that sac gets full. And the pressure of that sac then gets so great that the heart can't actually beat. So the pressure in that sac is greater than the heart's ability to beat. And so you can see it kind of all the way up in this chest. And you take, a forceps and some scissors and you just slice that open. Sometimes there's blood rushes out and you're like, okay, it's coming from there. Got it.
Yeah.
Sometimes it's not. And then the other thing you can do from the left chest is clamp the aorta. And so the aorta is the big blood vessel that runs from your heart down into your abdomen. Mm-hmm. And it kind of lives right above your spine in your chest. And so there's a layer of fascia that kind of engulfs it. And you kind of cut that open. And then you put a big clamp over it. And all these things are not without consequences down the road, right? But you're playing with this thought of, if he lives, I'll then deal with whatever problem this caused.
Yeah, for sure.
But clamping the aorta, you're basically stopping the blood flow to the lower half of your body. And so you're giving whatever blood they have left back to the heart, back to the head. So if they're short on blood and that's why they died, that gives you some time. Not getting blood to your abdomen for a period of time is not good and causes other problems. But we cut open this guy's chest. We did open the pericardium, which is that sac around the heart. Got a little blood out. Not enough to cause a tamponade or the restriction of the heart. They're giving him blood. They're giving him medicine to kind of see if we can't restart this. We were getting the paddles ready, the electrical paddles, to put directly on the heart at this point to see if we can't shock this thing forward. And as we're getting this ready, I don't see anything in there that would have killed him at this point.
Okay.
So I'm a little bit confused, right? Right chest tube's in there, not putting out blood or air, not in the right chest. Mm-hmm. The left lung is unscathed. The aorta, I didn't clamp because it was full. You could see that it was full of blood. The heart looked normal, didn't have a giant hole in it, and I didn't get a bunch of blood out of it. So I'm kind of scratching my head and with this guy's chest open, and all of a sudden starts beating again. Gets a blood pressure back, starts beating again. And I'm going, okay. We've made a lot of problems at this point. Like, we've made this big hole, like I've cut open. And so I was like, well, we got to go look at this guy's heart now, right? He's come back, but something happened. He just didn't die for no reason. So I called one of my very senior partners in. I was like, I told him what's going on. I was like, we're going up to the OR. I think this is heart. Can you come in and help me? Like, if this guy has a survivable heart injury, I want to make sure that we're doing everything we possibly can for him.
Sure.
So we take him in. He has this huge, cut down his stuff. But to get to like real heart stuff, you have to kind of do the open heart incision down the middle of the chest. So we get in there. He's stabilized. We get in there and cut it open, spread it like you would for a heart surgery. And we're looking at the heart, and the heart looks normal, like really normal, like not pissed off, beating well. Again, not a heart surgeon, but to my dumb trauma surgeon eyes, like, it looks like a normal heart. I don't know what I'm, and so we're kind of like, okay, we need to look at the back of this thing. Mm-hmm. There's a problem with looking at the back of the heart, though, is that You can lift a heart. The heart's hanging basically from suspensory ligaments at the top of it.
Hmm.
But when you tilt the heart up, you're basically pinching those big blood vessels at the top of it. So blood return specifically stops to the heart when you lift it up. So you only get a second unless you do. And, that's where a heart surgeon comes in, because they can fix something at the back of the heart because you put the patient on bypass. And then you can, do what you need to do with the heart.
Yeah.
But we weren't there. This patient wasn't on bypass. So we lift up the heart, and this guy has this incredible bruise on the back of his left ventricle. The big beating chamber that goes, right ventricle beats blood to your lungs. The left ventricle beats blood to the rest of your body.
Yeah. Yeah.
He has this huge bruise on the back of, red, beefy. And my thought is that a gunshot hole and it's just like sealed itself off? And this is going to be a problem later down the road.
Right.
But it just looks like a bruise. I'm kind of feeling it. It doesn't feel to me like there's a heart, a hole in the heart. And again, that principle of we've bought ourselves time, and so we're there, and I was like, let's get a heart surgeon in here, because I don't know what the natural consequence of this is.
Right.
And there was great heart surgeons at the hospital in Chicago. One came in and was like, do you need to put, his first thing was like, does this guy need to go on bypass? And I was like, I don't know. Come look at this and tell me.
What does that mean, go on bypass?
So that's what they do for open heart surgery. And so basically you're putting a big cannula into the blood return to the heart and a big cannula in the blood out from the heart. And then it goes to a heart-lung machine, which beats the blood and oxygenates it in another machine.
Okay.
And so you're taking the heart out of it. The heart's only job is to pump blood. Yeah. But you're bypassing that entire circuit that with the lungs as well by doing that. And so you need something to beat it and oxygenate it. And there's, heart surgeons are very good. Almost every heart surgery they do involves first step going on this machine so they can then touch this heart.
Yeah.
And I was like, I don't know if we need to go. I don't even know if there's a problem. And so he got in and he looks at it, and like I said, we can only look at this thing for 3 or 4 seconds at a time. Then you need to give the patient time to get blood back and recover. We're looking at it and he's feeling it. And, we talked about, like, do we put some type of patch on top of this just to, boots and suspenders it or something like that? And ultimately we decided to do nothing at the time. He goes, this guy's fine. His heart seems to be beating. We'll do workup, tomorrow and do a heart cath to see if the blood vessels in the heart are okay. We'll do an echo to make sure everything's beating okay. And if something needs to be done, we can do it in a more elective fashion and get all the things that we need. And so we end up spending a long time, man. More than an hour and a half closing up all the damage we made, closing up this middle thing, this incision that we made on the side of his chest while he was dead is always a nightmare, because when you're doing it, the heart isn't beating, so they don't bleed. When you get them back, all the things that you cut that should have bled, all of a sudden start bleeding again.
They start bleeding.
And so it takes, and you're not making this like you would a normal surgical cut. You're cutting through muscle and things with a knife. And you would never do that in a controlled setting. You would use electricity to kind of cut through that muscle very slowly to make sure it doesn't bleed. But now you've got all this just raw cut muscle. So it takes a while to get that all kind of sewn up. Yeah. Make sure he's not bleeding, and we close him up as well as we can. The next day, the cardiologist come in, do a heart cath, do an echo. His heart's fine. He gets his breathing tube taken out. I think he leaves the hospital. He had those chest tubes. Those chest tubes stayed in for probably 5 days before they came out. think he left the hospital, walked out a week later after being what I assume was a glancing blow to the heart from this bullet. I don't know if it was the actual bullet, the shockwave from the bullet, or something like that, but something pissed off his heart. I still,
Gosh,
I gave presentations on it and stuff at academic conferences and showed this picture, and it was one of the best pictures of just this normal heart with this big old bruise on it.
What gets in there to get that kind of picture? Is that a CT or an MRI?
So the picture of the bruise was there was an OR camera for HIPAA violations that lives in the OR, and it was a nurse, me being like, "You ready?" And picking it up, and then just with like a digital camera that the hospital controls to make sure those pictures don't go anywhere else. But yeah, it's just like a digital camera.
That's unbelievable. That's an incredible story, man.
Yeah, it's one of those things. There's that case, and there's one other case where it was just like, I think it's where experience comes in. Like I didn't even know that honestly was a possibility.
Right.
Right? Like,
Right.
I didn't know you could get shot in the heart and it not go through the heart, and you can bruise your heart without damaging it. I didn't know that could kill you temporarily. It probably, like, that bruise probably stunned the electrical system of the heart.
Yeah.
And that's why he died for a few minutes. But it wasn't a structural blood flow issue. It was strictly just an electrical issue. And eventually, it figured itself back out and it was fine. But again, you would never know. And until you do that one case, that's a case of one. So, like, now, if that ever happens again, now I know.
I mean, there could literally be a chance that that's the only time that ever happened ever, right?
Maybe, I mean, theoretically, I don't ever consider myself that special, and I've had mentors who have done this trauma surgery at high volume centers for 30 and 40 years, and then the military surgeons, which we worked with in Chicago as well, who come back, were coming back. They've had a lifetime of experience in a deployment, and so nothing replaces experience, because you can't read about this stuff.
In episode 13, we cut out a little clip. It's such an incredible story, and that's just done so well out across the internet. So many people have commented and seen it, where you go like this. The famous bullet up against the heart that you saw. You didn't go too much. I don't know the details of it, but you just sort of glazed over it. Like, go into detail about that case. How does a bullet rest up against a guy's heart without him dying? And you said he walked right out of the ER room.
So the case from episode 13 where we could see the bullet moving?
Yeah, you were doing that with your finger. What was that? What happened there?
Yeah, so it wasn't resting against the heart. It was in the abdomen, and it was resting against the aorta, which was the big blood vessel that goes kind of down the abdomen.
Yeah.
And again, it was one of these things where we found the hole. The hole was very obvious. We found that bullet on X-ray, and then during the case, you're kind of doing it and went through a portion of the first portion of the small intestine. It went through the pancreas, and then it dove down into the area again. That's the liver pancreas surgeon area that, like, I try not to go into unless I really have to. And so, I'm sitting there with my residents and fellows at the time, and again, the guy's doing fine. We fixed the hole in his duodenum, which is that first portion of the small intestine. We kind of drained his pancreas. That's not an issue. Mm-hmm. But you're like, where did this bullet go? And it was one of these things of, like, to get to where I thought it had to go was going to be a really big deal. And again, like, I don't know if I'm a good enough surgeon to do that. I've done, there are surgeons, those liver pancreas surgeons, that do it on a routine basis.
Sure.
I've probably done that mobilization less than 10 times in my life. And if I have to, if the patient's dying, like, yeah, give it a whirl. But again, like this patient's not in a bad spot.
Right.
Let me at least get some more information. And if something needs to be done, let me get at least one of my senior partners in here to help me with this so we can give this guy the best chance ever. So he gets a CT angiogram. Or no, I think it was just an angiogram. So inject contrast into the blood vessels, and then they're shooting a live X-ray, kind of. And as we're doing that, you can see where the bullet is, and then you can see the aorta light up with the contrast, and then you have time. Like, this is real time. It's a live X-ray.
Live X-ray. Wow.
And so every time the aorta, the heart beats, the aorta also kind of beats too, just like you can feel your pulse. There's pulsations going that. And we're looking at it on the screen, and you can see the bullet. And every time that heart beats, that bullet moves. And again, I don't know the natural consequence of that.
Right.
I don't think it's good. A piece of jagged metal beating against the aorta, and this was a young kid, over the next 60 years, I would have to imagine that some untoward consequence comes of that.
Yeah.
And so, again, we sat around a table with a bunch of people that are much smarter than me going, what do we go get this? Like, I don't want to be back there. Do you want to be back there? I don't want, And so it was me and like two of, the most experienced surgeons in our group. And we all kind of went in there together and we're like, we need to go get this bullet out. And we had done a lot of things where if this goes haywire and all hell's broken loose, we have because we had time. Again, time is your friend, right? And so we put all these clamps above and below it and on the sides of it. So if we touch this bullet and all of a sudden it rips off the side of the aorta, we have some semblance of control to fix it.
Yeah.
And it takes a couple hours, and we carefully dig back into it, find it. My partner grabs it and pulls it out with a surgical forceps, and we all just hold our breath. And then we're kind of looking, and the aorta's fine. It's not even a bruise on it.
Gosh, that's so cool.
And so we took off all the things that we had done just in case this went terrible. And then you're kind of sitting there going, did we need to do that? Like, I don't know. Yeah. But it makes me sleep better at night knowing that this guy's not going to have his aorta explode from a bullet eating into it in 20 years.
Yeah.
So that's what we did. But again, the trauma textbooks are this big, but they'll describe general principles, right? And none of these things are part of the general principles.
Right. Gosh, that's such an awesome story. I love that one. So you got a case, your people are running around. I could just see it. It's like frantic, chaotic. You're trying to keep somebody alive. You're giving them blood. What happens if you give them, I think it's like A and B and all the different bloods. What happens if you give somebody the just straight up wrong blood?
So there are lots of different doctors, and there are doctors that specialize in blood. That would be a much better question for them. My understanding is you die in large volumes, right? You can probably take a little bit of it, but your blood starts rejecting itself, and your immune system starts attacking that blood with the immunoglobulins on it. It thinks it's foreign and it's going after it.
Yeah.
And I would have, again, I don't even want to talk about this because I don't think I know. But my gut is that you kind of get blood clotting and your blood stops working, and like you don't do well.
Yeah.
And so what happens kind of with that massive transfusion protocol, and the reason it can go for such a long time, is the first 3 coolers of the massive transfusion protocols that I've worked up with have been O negative. So it doesn't matter what their blood type is. And when they're giving whole blood, kind of in the helicopter pre-hospital, it's O negative because anybody can receive O negative. It has no immunoglobulins on it.
That's anyone can take Anyone can.
Anybody can take it. So it is immunologically inert.
Incredible.
Nobody's bloodstream would look at it and go, "Oh, that's a problem."
Hmm.
You know, A, B, A, B, and then the RH factor, which is the plus or minus when you hear blood types. A is a type of immunoglobulin, B is a type of immunoglobulin, and then RH is a type of immunoglobulin. And so if you have A, you have A. If you have AB, you have both A and B. And then you can be AB positive and have that RH factor and stuff like that. So those are all sites that your immune system can kind of go after. But O negative, O is referring to you don't have A or B, and then negative is referring you don't have RH, so there's nothing to target. So the first blood you give, or the whole blood that you give in an emergency circumstance, is O negative. The problem with O negative is there's only so much of it. It's very desirable. You know, in a perfect world, we would only transfuse O negative blood. You know, it would take away the need for blood typing within the hospital. Doesn't matter what type of blood you have. Like, we're just going to give you O negative. It's going to be fine.
Right.
But kind of supply and demand, we would prefer to give you, if you're an AB positive, we would prefer to give you AB positive blood because we have a lot of it. And so when they come in, they start getting blood transfusions with those first three coolers. The nursing staff takes blood away from those and sends them for typing. And so by that fourth cooler arriving, they're getting actually the blood type that they should based on the blood that they have intrinsically.
Got it. Okay, that's a big thing. Back in episode 13, again, you just touched on this. I want to go into detail today, though. You mentioned that there was a time in your career that you had, I want to say it was Chicago, but you said it was normal to have, I think, 20 beds as
Yeah.
one trauma surgeon. Get
Yeah.
me there. What does that feel like? And you said there was a time when they were all full.
Yeah. And it kind of goes back. And so the picture is not as dire as it sounds, right? So as you know, the trauma surgeon, I'm there. One of my partners is at home on backup that can be called in and can be there within 20 minutes.
Okay.
So if all hell breaks loose and I need another hand, someone's 20 minutes away.
Okay.
And there's, but as the trauma surgeon, I'm sitting there as the captain of the ship. But there are so many other people there, right? There's an army of nurses, and it was a teaching institution. So we had, one or two fellows who are fully trained general surgeons that are just learning to do advanced trauma.
Okay.
And then there's a bunch of surgical residents there that are there to help and who are very adept at trauma care in and of themselves. And so as kind of the trauma surgeon, you're kind of managing all these different teams. And, in Chicago, oftentimes there was 3 teams that kind of worked somewhat separately.
Okay.
Of like, okay, I'll get this patient, the next one comes in, team 2 gets it.
Yep.
But kind of as we talked about, like there were, 2 big trauma bays that had, where if you're going to do one of those cuts on the chest or something like that, had all the accoutrements for that. And then there were kind of 20 beds surrounding those trauma bays. And it was just kind of the sad reality of trauma care, right? Like there's a lot of stuff that happens that the patients just don't make it. So there's a selection bias there, and there trauma that as a trauma surgeon, I never know about because the police and the emergency medical personnel just decide in the field that this person's dead. And if they know that person's been dead for more than 10 minutes, we don't even do much when they get to the trauma bay, right? Like there's only so much metabolic reserve that patient has.
Yeah.
And then there's that trauma that, something needs to be done. Days, hours, weeks to prevent permanent disability or death. But like you have time. You have time. And so the 20 beds around it are a lot of that patients that have time. The car accident that has a broken pelvis that's not bleeding. Like, yeah, that pelvis needs to be fixed, but that's going to be tomorrow.
They're not dying.
And
Like
yeah,
they're
they're not dying. And
got it.
so,
Okay.
the amount of people who are actively dying, is very small. And even in the busiest nights where there were tons of gunshots, most of the gunshots that came in were fine. They were extremity gunshots without vascular injury. They broke a bone, or they didn't hit anything, and they were okay.
Yeah.
And there were some that came in that were bleeding. There were some that come in those extremity shots, and you're like, oh, you took out the blood supply to your lower leg. We're going to need to fix that. Again, better surgeons than I am. I would prefer to do lower extremity revascularization. A vascular surgeon is much more adept at doing that.
Yeah.
Could I do it in a pinch? Yes. If it was my leg, would I want a vascular surgeon to do it? Absolutely. And so, but it's even that the blood, the gunshot to a thigh broke the thigh bone, broke went through the femoral artery. And so below that, it's not getting blood supply, but it's not bleeding. It's kind of sealed itself off.
Yeah.
You're like, okay, that needs to be acted upon. We got an hour and a half to kind of get this going. And you kind of need to mobilize teams. For that case, like, you need to call the orthopedic surgeon in, because they need to put an external fixator on that bone to put that bone back where it should be and stabilize it. So then the vascular surgeon knows exactly where it goes, and the leg's not doing this while they're trying to do their repair. And then the vascular surgeon's repairs that artery with an interposition graft or something like that.
Yeah.
So, but when that patient comes in, we stabilize them, ABC, check them out, x-rays, and then you find out his injury, and you're like, that's a bad injury. We need to fix that. But it's not that urgent 10-minute hour thing. It's, okay, we need to get this done quickly, but it's not that hour. That hour is very rare. Just because of the nature of EMS. It takes time for EMS to get called in the first place after a gunshot.
Right.
After they get called, they need to dispatch to there.
Yeah.
Time on the scene, stabilizing the patient. And it takes time to transport them back. If that patient had an injury that if you intervened upon within 20 minutes, they're bleeding from their liver. If we could get them to the OR, start getting blood in them within 20 minutes and get them to the OR, maybe they have a shot. Takes them an hour to get there. They've bled out. And so it's just a race against time.
Yeah.
It's a race against time. And in, major metro areas that have big trauma centers, there's a big push for EMS to just scoop and go. So EMS are amazing people, right? They do so much with so little, and doing ride-alongs with them and things of like, oh, like, you're gonna put a breathing tube in somebody, show me how you do that. I'm like, oh, you're doing this on your knee in the dark on the ground, like, and it's hard for me to do it on a bed with all the lights in the world, and these guys are accomplishing like amazing things in the worst circumstances. And so, but in that circumstance where the patient's bleeding, like, we need to get blood in them. And if you're close to a trauma center, there's nothing EMS is going to do if they don't have blood that's going to really help that patient. So throw them in the back of the ambulance and go. And you can get something done on the way, cool. Yeah. But do not spend time on that scene, because like, they need to get to me. Not that anything I do is going to get special, but they need to start getting blood poured into them. And a lot of times, even if they have blood on it, 2 units is going to buy you 10 minutes. So they need to get to us, and they need to start getting that blood that we can push in 2 units in 30 seconds. And start getting it over and over again, and let me figure out what's wrong, and let me try to stop it. But the body is an amazing thing, and it has a way of regulating itself. And it's all blood pressure, and there are different, areas of the abdomen. There was one case I remember where it was a young kid, like 16. And he got shot kind of right above his pellet, like right below his belly button. bullet hole out the back. Like, okay. And so, but again, fine. Um, um, relatively fine. And so we're like, okay, this clearly, went through his abdomen. Because sometimes bullets escape the abdomen. There are tests to like see if this bullet actually went into this abdomen. But this went immediately front to immediately back. There was no possible journey that he couldn't do. And then we're like, okay, let's just take him to the OR and I know where the two holes are now. So I just have to look in that two area between those 2 points to figure out what's injured. The liver, the kidneys, spleen, stomach, those are all not in play here. It's just this low pelvis. And so we'll look, and I was like, if I can't figure it out, there's some additional testing we can do both in the OR and after. But like, this guy's fine. So like, I don't think anything is really bad with him, right? Maybe you hurt his bladder, maybe a hole in kind of his colon or his rectum. We'll fix that. That'll be all right. So we go to the OR. He gets his breathing tube studs in, and like, we're not taking our time, but like, we're not trauma prepping him. Like, we're doing a real prep. We're setting up for like a real surgery, getting everything that we could possibly need. And a nurse, part of surgery is you put a tube down their nose into their stomach to suck out their stomach, and you put a tube in their bladder to take out the urine and see what their urine output is. And that's a good indication of kind of their resuscitation and how they're doing overall.
Yeah.
And nurse puts in the catheter into the bladder and goes, "Hey, Dr. Boron." And I go, yeah, what's up? She goes, "It's bloody." And I'll go, "Oh, okay." And I was like, I kind of figured this guy had a bladder injury. That would make sense. There's proof positive that that's a bladder injury.
Yeah.
And so we're prepping, and I'm putting on gown and gloves and, getting everybody ready, talking to the residents and fellows about kind of the plan of what we're going to do. And I just hear this large bang splat. And it was like I hadn't heard it before, but it was loud, and it didn't sound like someone dropped something. It sounded like, I remember the sound being like, what was that? And I look, and the entire floor of this pristine OR is now covered in blood. And the anesthesiologist, the guy who's running the breathing tube and the medicines and doing the resuscitation and stuff, goes, "Dr. Boron, he became unstable. We're going to start transfusing him." So we have that cooler of blood ready for him because we didn't know what we were going into. And he starts transfusing him, and I look, and the bladder drainage bag had exploded and fell on the ground from just bleeding. And what had happened was the bullet had gone through the bladder, but had also gone through the iliac artery, which is your aorta about the level of your belly button bifurcates to go down your legs and kind of goes down the back of your pelvis before it becomes the femoral arteries on your femur and your legs. So you have those iliac arteries, and it had gone through an iliac artery, or like half of it. And it had been fine. It didn't go through all of it. There was still blood flow, some to the leg. I remember we checked pulses in the leg, and the guy had some pulse in the leg. It was a little decreased, but maybe there's some pressure in there. Like, he has a pulse. That's all I care about at this point.
Yep.
And what had happened was the bladder and this injury live in this artery, live in the retroperitoneum, which is kind of like the back office of your abdomen.
Yeah.
It's its own separate thing. It's kind of separated from all your intestines.
Yeah.
And it had kind of, tamponaded itself, or there was enough pressure in it where it wasn't bleeding anymore, and there was nowhere for it to go. So it just kind of stopped bleeding. And he lost 500, 600, 700 cc's of blood into this, but he was a young kid, and so he could handle it. He was fine.
Yeah.
But when we stuck that catheter into his bladder, all of a sudden it opened that space. And now that artery could free flow and it was connected directly to his bladder.
Mm-hmm.
And so that artery was literally just free flowing into his bladder and out this catheter.
Gosh.
And it was one of those things where, okay, you clamp that catheter again, like, okay, that was working before, let's do that. So you clamp it again so it stops. And then we got in there and there was that artery injury and we needed to fix the bladder and all these things. But I still remember that sound of that thing falling. And again, it was my thought initially was, I didn't know that could happen.
Right.
Like theoretically, like we're talking about it now, I'm like, yeah, it makes total sense. But like I didn't know that like you could be totally fine and like it could tamponade itself off and that like putting in the catheter might be the tipping point where all of a sudden you send this guy unstable. And the guy ended up doing fine. He was 16. We were on top of it. It was fine. But again, that wasn't in the trauma textbooks.
Right. Did you ever see it again? Anything like that?
No. Yep. Again, these are all one-offs. And I had this wonderful mentor who was like one of the forefathers of like trauma surgery and worked with Grady in Atlanta for forever. And like he was so interesting to talk to because like stuff like that, he would be like, I've seen this 2 or 3 times. But he has had like a 35, 40-year career and has seen this like twice. And, again, experience is a wonderful teacher.
Wow. I remember a story like that from your original episode where you said you would have never picked up on something, but a guy was there in one of your procedures that had like 30 years. I forget what it was, but I remember you saying that.
I mean, the biggest advice I give to like young surgeons or surgeons like starting their careers is really like lean on your older partners, man. Like the amount of, because surgical training is really long. I did 7 years of surgical training after med school to be able to do this. It's really long. I learned a lot. I did a lot of procedures. I felt very confident in my skills. But every day I did the job, there was like, never done that before, or I didn't know that could happen. And having mentors that you can be like, hey, have you seen this? Have you dealt with something like this? How would you approach it? How do you think about it? I think it's just invaluable. And the pearls that an experienced senior partner can give a young surgeon and get you out of trouble and keep you out of trouble. Hey, Dr. Boron, I wouldn't do that. Like, let me tell you why. I did that as a junior partner and I regretted it. So don't make that type of things. Like, learn, I think it's like that in every industry though. This one is just the immediate consequences are much more apparent.
Much more apparent. Oh yeah. Wow. All right. Last area of focus. What's just the absolute, to the normal person, the most gruesome thing that you ever saw that we would think is just like somebody came in, I don't know, when their brain was sticking out of their head?
I think gunshots are bad. And for a trauma surgeon, they're exciting because like there's like an easy, not easy, but again, you're playing the add to 2 game. Yeah, connecting the dots, and it's there's an orderly process to things.
Yeah.
The bad motorcycle accidents and bad car accidents, really motorcycle. Like, you love a motorcycle, God bless you, but like, please be careful. And the things I always think about that really, I was like, where do you even start here? Were these bad pelvic injuries that come from like a motorcycle and like the force kind of going forward and your legs are separated and the force is coming through your pelvis. And your pelvis kind of looks like this, and it's attached in the back by your sacrum and kind of holds itself like that. When you fracture it, it tilts itself, it moves itself. And then within that pelvis are a bunch of things.
Yeah.
The blood vessels that we talked about, those can get injured. Those all have branches that run throughout the pelvis that can bleed if something's fractured.
Yeah.
Your bladder lives down there. Your
Yeah.
rectum lives down there. The tubes that connect your kidneys to your bladder live down there. And so the one that got me was this guy was on a motorcycle and had kind of the trauma come right up through his pelvis. And it had broke open his pelvis, what we call an open book pelvis, where your pelvis kind of does that. Open book pelvis. And then he had this huge wound in the center, like the force of it ripping his pelvis open had created a wound kind of in his private area. And poop and blood was coming out of it. And he ended up breaking. It was just the most foul. And the guy's like, that's not his only injury. He's got a head injury. His arms are broken. He has his pelvis that's mangled. And then inside his pelvis, all the internal organs are also mangled as a result of this. And you're kind of going, okay, like, it's that whole, how do you eat an elephant? One bite at a time, right? So like, okay, what's going to kill him first? And so you kind of bring the pelvis back to where it was supposed to be, first step. And, that usually we do that with kind of like a big Velcro strap kind of thing. This wasn't going to work for him because all his guts were in the middle of that. So we got our orthopedic colleagues to come in and put screws and a big bar to kind of put that over to get his pelvis back where it was. Okay, what's next? Well, this guy's bleeding a lot. Meanwhile, he's got a head injury too, but we scanned his head. Neurosurgery's like, nothing needs to be done right now. Okay. And so again, like that pelvis area, sometimes you can pack it again, like we do over the liver, you can pack it, but we're not going to be able to pack this because it's open to air because of this huge wound. So you call, again, this takes a village. You call your radiology colleagues and they go in and stick a catheter into one of the blood vessels and then go down, find the specific blood vessels that are bleeding internally and inject foam into those specific blood vessels from the inside to get them to stop.
Wow.
And then you're like, okay, well, so pelvis is back where it's, I guess, supposed to be. Yeah. We're not bleeding anymore. Okay, let's dive into the mess that's in there. And so we open up his abdomen. His rectum was basically sheared off his colon, just gone. There was feces kind of everywhere within his abdomen. So you end up taking the colon and kind of giving them a bag on their abdomen that they can poop out of. Again, live to fight another day. His bladder was just ripped to pieces. And, I've done bladder injuries. I've done a good bit of bladder injuries. Yeah. I looked at this and went, I can't fix this. And so we had some time. The patient was stabilized. Get urology, the surgeons who work on bladders, kidneys, and ureters in, and they end up just putting tubes in this patient's ureters and then out the side of the abdomens, completely bypassing the bladder because it was gone. And then a bunch of small intestines and little bleeding. And the guy ended up having an open abdomen where we weren't able to close his abdomen back after the surgery. He had that for about 2 weeks until we were able to kind of cinch it back. And then he had this huge wound kind of between kind of his penis and his anus where all this trauma happened that was infected and like it needed serial debridements because it just bathed in poop for a while. And eventually, we were able to get the infection out of that, put skin grafts on it to get it healed. But then he had, multiple surgeries on his pelvis to get that stabilized again. And eventually he left the hospital. He went to a rehab facility and will need, months and years down the road, reconstructive surgery to reconstruct the bladder, rehook back up his colon, and the rest of this. But I mean, it was one of those just so disgusting. And it's just everything was wrong, right? Everything was wrong, and everything was wrong in the same area. And so, like, just, feces, urine, blood just pouring out of the bottom of this guy. And what do you do with that?
Does it even matter? Like, when you get somebody like that, do you need to know what happened? It doesn't even matter. Like, do you need to know he was hit from this angle, or you don't even need to know that.
Yeah, it's one of those things. So again, like, our pre-hospital colleagues have been trained very well to, like, gather information. Like, he was going north, they think he was going 80 miles an hour.
Yeah.
He was wearing a helmet. He hit this at the side of it, was thrown 30 feet. And I'm happy to hear it. I don't know how much in my brain that, like, matters. Yeah. Like, I'm looking at it and I'm like, I'm going to have to image this guy's entire body to see what's injured. I can see bones that are fractured. I know this pelvis thing is a problem. Yeah. But how he got here, I don't know if it matters. I mean, I guess part of it is entrenched in me and, like, it helps, but out of curiosity, sometimes you're like, how does this even happen to a person?
What was that? What exactly happened? Did he get
motorcycle, high rate of speed on I-75 and hit the back of a car that was stopped, and it just, his bike kind of went through him.
Oh my gosh! Wow. Okay, touch on this, then we'll wrap up. That was the most incredible hour and 36 minutes. Oh my gosh, that was awesome. What's your drive home a day like that? Your ride home from work, is it, honey, I'll be home and tell the kids I said? Is it a normal drive home, or does that affect you in a different way?
Yeah, I think it depends if patients live and die, right? And so, sometimes you go home and you had a really big win, right? There was a patient that you worked on for, it's a 24-hour shift. You worked on the same patient for 14 hours and you left and they're doing great. And you're like, all right, that was a win.
Yeah.
And then there are other cases where they don't do well, they don't live, and you sit there on the drive home going, did I miss something? Was there something I could have done better? Was there something I could have picked up on earlier that would have gave this guy a chance? And, like, that all lives with you. And, the surgeons that do it for a while and make a career out of it, I think, are able to compartmentalize those losses a lot better than other people. I always struggled with it. I thought it was very hard to have those big emotional highs and lows and then try to go home. And then you run into the other, like, if the person that you're going home to, or, your support group of guy friends, if they're not medical, how do you describe it to them? How do they understand what's going on? And it's just very tough. And so I think there's a big focus now, especially on, like, emergency personnel, ER doctors, trauma doctors, on mental health. And I think that's great, because it was kind of the unspoken of, this doesn't affect you. Go home, come back tomorrow. Yeah. So I think there's a big token, but, scoreboard matters. And, if you won that night, you feel great. You feel unstoppable, right? Like, I did something that most people can't do. Most people don't have the stomach for, and the people that don't have the stomach for it, do have the stomach for it, don't have the training to do it. Like, that feels awesome.
That's incredible.
But then when you leave and you're like, man, if I would have known, or was there something I missed, or was there something as a team we could have done better? Was there some process that I could improve on later that I can go back to the hospital and work on, of, like, this can be improved? Like, those are the things that go through your head, because if they make it to the hospital alive, like, the thought is, like, I can get this guy out of here. Their body has already passed the first test. It's made it here.
Yeah. Wow, that's great. Wow. All right, man, that was an awesome almost 2 hours, hour and 45 minutes anyways. Man, thank you so much. I have our next episode literally outlined. I've been taking notes.
Okay.
Our next episode set up, and we're going to start, you're going to update us, not today, but I want to hear everything that's going on in the skin world. I know you're growing skin, and that's just fascinating. We talked about it in episode 13.
Yeah.
I'm going to
Yeah,
get
we can do an entire episode on these stories related to burn injuries as well.
Yeah, yeah, we will for sure. So I'll have you on again real soon. But for today, man, thanks a
Absolutely,
million. That's awesome.
absolutely, Jeff.
Awesome. And just stay on after it'll tell you 99% and then it'll go to 100. Okay.
Okay.
Thanks. See you.
Yep.